Good afternoon. I am Joe Antos at the American Enterprise Institute. Welcome to AEI's virtual event, Can Employer Disruption Bring Competition to Healthcare? Today's panel will discuss promoting a more competitive healthcare market, but from a consumer perspective. Consumerism in healthcare is often discussed in federal policy circles, as everyone on this webinar knows, but the American health system is not very consumer friendly. Most people in this country get their health insurance through their jobs, and in most cases, plan options are limited. When you go to the doctor, you don't know what you will pay out of pocket, even if it's a routine visit, since the cost depends on whether you've satisfied the deductible. If you need an MRI, for example, you can't easily compare prices, and you are often referred to the nearest imaging center, which might well be convenient, but at a higher cost than driving down the road to the next provider. Alex Azar told this exact same story about his own close encounter with healthcare in his first speech on becoming HHS secretary. Although I strongly suspect that his story was apocryphal, the point was correct. And it's played out hundreds of times a day across the country for so-called shoppable services. That's services where comparison shopping should be possible even today. The fact is that we don't know what medical services cost. We as patients don't know what medical services cost. We don't know whether there's another provider who might be better at treating our illness. And we are typically limited to the providers in our insurers network. As far as the health system is concerned, we are patients. That is, we are inputs into the system, not consumers. Government policy has promoted a pro-consumer agenda. Things like price transparency, provider performance measures, new insurance designs. These are all things that are intended to promote cost awareness on the part of patients and providers. But change comes slowly, if at all. The Centers for Medicare and Medicaid Services released a regulation last November that requires hospitals to publish the negotiated rates they reach with insurers for healthcare services. Naturally, hospitals sued. And on Tuesday this week, the U.S. District Court for the District of Columbia ruled that this requirement is legal. I'm sure the case has already been repealed, and that will go on for quite some time in the courts. Whatever the legal merits of that case, however, the key point is that the government is trying to compel providers to reveal prices through regulation. That's not how markets normally work. Almost no healthcare provider voluntarily provides price information upfront to their patients. Moreover, the information that the government wants to make public is not actually the price that consumers need to know or care about. The government wants hospitals to post the prices they negotiated with insurers. Consumers want to know how much they will have to pay out of pocket after insurance pays its share. Those are two different concepts, two different numbers. You can't thread that needle at all. Okay, that's my introduction. Let me introduce the speakers, starting with Steve Hyde. Steve sees a strategy that can give consumers real control over their healthcare. Steve has a long career running a variety of healthcare organizations and is now a consultant with Stroudwater Associates, which is a national healthcare consulting firm. His latest book is titled How Jeff Bezos Can Fix Healthcare, Leading the Transparency Revolution. It's just a coincidence that the book is available on Amazon. Following Steve's talk, Bob Grabe and I will offer some reactions, and we will open the discussion to the audience at the end. If you have any questions or comments, please email them to sarah.rogers@aei.org, or, although I think this is less reliable, you could always try Twitter with the hashtag healthcare disruption. Okay, now, Bob Grayboys. Bob is Senior Research Fellow and Healthcare Scholar at the Mercatus Center at George Mason University. His recent book, titled Fortress and Frontier in American Healthcare, addresses how we can make healthcare as innovative in the next 25 years as information technology has been in the past 25. Yes, Bob's book is also available on Amazon. Let me hasten to add, however, that Amazon is not sponsoring this event, and none of us is auditioning to replace Atul Gawande at Haven Healthcare. Haven, by the way, is a collaboration between Jeff Bezos, Warren Buffett, and Jamie Dimon that started 2 years ago. And at least the press release said that they wanted to promote better care at lower cost. Everybody supports that goal, of course. Actually achieving it is another matter. So with that, let's start with Steve.
Thank you, Joe. Let me cue this up. Thank you, Joe. And thank you, AEI, for sponsoring this session, and to all of you for attending. We all know healthcare costs too much. Less known is the variable quality that too often delivers a patient into the hands of what Dr. Marty McCary calls Dr. Hodad, hands of death and destruction, instead of those of a brilliant surgeon with brains in his fingers. Meanwhile, high deductible health plans designed to steer consumers to lower price care have fallen victim to the enforced price secrecy that Joe talked about, that more often sends a Portland, Maine colonoscopy patient to a $4,526 facility instead of an equally qualified one nearby costing only $559. We've all experienced terrible customer service in healthcare. In fact, it's almost a non-subject, non-issue. But few realize that our primary care physicians themselves are now so fed up with insurance red tape that half are considering career changes, 2/3 recommend against a career in medicine, and 7/8 have had patient conditions worsened because of payer decisions and delays. And while we love to criticize the government's role with good reason, the employers who insure the majority of the population have performed no better. I assert that virtually every problem in healthcare would be solved if we could figure out how to get consumers to demand and act on the answers to two simple questions. First, for my medical needs, which providers offer the highest quality, most appropriate care? And then second, of all those high quality providers, which one is cheapest? Now, consumers don't have the clout to demand this information. Their inputs in the system, as Joe said, they're patients. To get that kind of clout, they must be given control of all the money. That, of course, means taking it away from the insurers and the third-party companies that are hired to process and pay the claims. But doing this can turn medical care at every level into a retail purchase that we can buy the same way we do everything else in our consumer-dominated economy: food, clothes, cars, houses, recreation, and prospectively affordable insurance that pays for necessary high-cost care that few of us can afford on our own. Achieving this will require 5 major simultaneous changes in the roles of medical providers, health insurers, private employers, and healthcare consumers. That's all. First, providers must stop negotiating with insurance companies and just simply set and publish their own uniform retail prices for their private patients, regardless of payer. Insurance payers, likewise, must stop negotiating with providers and simply establish and publish how much they will pay for any given service, regardless of provider. Third, insurers must also bring their claims system into the 21st century to provide no hassle, real-time claims management and payment. Fourth, employers must modify their employee health plans to incentivize their members always to seek the best care at the lowest price. And fifth, employers must also provide their members with actionable, real-time quality and price information via smartphone apps and other means, since high deductible health plans have taught us that incentives without price information aren't enough. Then, with this in place, for most of the care most consumers need most of the time, this should all be as easy as buying a book on Amazon. More complex care will provide additional assistance from doctors, from patients, doctors, and advisors. But ultimately, as with Shakespeare's truth, value will out. Okay, now comes the hard part. How do we get all of these fiercely independent players to simultaneously change their entrenched behaviors and profitable business models to make this happen? The government could force it, but I don't see that happening. So could a large insurance company like a United or an Aetna, but I'm confident that won't happen either. That leaves one player with the unilateral power and influence to initiate and spread, ultimately nationwide, all these changes, and that's a single employer. In other words, a single, very large, private sector, self-insured, technologically sophisticated employer with deep pockets, strategic patience, and a willingness to suffer the slings and arrows of outraged incumbents to make it happen. Someone, for example, like Jeff Bezos, or Satya Nadella at Microsoft, or some other innovator in pursuit of a major transformative business opportunity. Here are 4 reasons why a single employer can and should do this. First, the most important strength such a company has as a self-insured employer under the 1974 ERISA Act is that it is the insurer, as is virtually every company in the US with more than a few hundred employees. In Amazon's case, it is the risk-bearing insurer of more than 500,000 members, with 100,000 of them concentrated in the Seattle area, which to my mind represents an ideal prototype opportunity for this program. Only now, the company will have to actually behave like an insurer by bringing in-house all the administrative functions it has always farmed out to functionally obsolete third-party claims administrators, value-subtracting pharmacy benefit managers, PBMs, and unnecessary preferred provider networks. By insourcing these functions, such a company can implement transparent reimbursement policies in concert with a streamlined real-time claims adjudication and payment system that I can promise you will be extremely attractive to medical providers. Second, in its role as employer, this company can unilaterally restructure its own employee health benefits to create the incentives necessary for passive patients to become value-savvy consumers. Essentially, this means changing to a full replacement, modified, high-deductible health plan with significant employer contributions to the members' tax-free health savings accounts, or HSAs. Third, a company this size has massive contingent consumer purchasing power that, when combined with the advantage of simplified billing and immediate payment, can greatly facilitate the voluntary recruitment of providers willing to at least experiment with transparent, competitive prices for their services, products, and prescription drugs. It's worth noting that if Amazon's own self-funded health plan were spun off as a separate company, it would sit near the midpoint of the Fortune 500 list of largest US companies. So it's a bit of an exaggeration to say that Amazon is really an insurance company that runs some retail and computer storage stuff on the side. Fourth and finally, such a company would be able to create the consumer-friendly smartphone app and support services that can shine a bright spotlight on provider value. Behind the curtain would be a seamless cloud-based IT and member support infrastructure focused on always guiding members to the best medical care at the lowest price. So let's look at how this would work by imagining you work for Amazon after Jeff Bezos has implemented the system. You want to see your primary care physician, Dr. Helen Thatcher, because your knee really hurts. You open the Amazon Insurance app on your smartphone, click Schedule Appointment. After answering a few simple questions, it says you need a 20-minute visit with her that will cost you $78 after Amazon's insurance coverage. You also see your Amazon contributed HSA balance is $1,800. So you approve the price and select a convenient time for the appointment. When you arrive, you're a little surprised, you're overjoyed to discover she no longer makes you fill out the usual plague of handwritten registration forms. She's already received all your updated information from your phone. In her office, she examines your knee and tells you she needs to get an MRI to aid her diagnosis. She clicks the proper service code on her tablet, and the app on your smartphone instantly displays the retail prices for 8 nearby imaging centers. But what you really want to know is how much you will have to pay after Amazon pays its share. The app accordingly shows the lowest retail price $200 scan will cost you $200. Another priced at $800 will cost you $320 after your insurance coverage. And the most expensive $3,500 hospital MRI will cost you a nosebleed-worthy $3,000. Since you see that the $200 facility has a top 5-star quality rating, your choice is easy. You click it, schedule a convenient time, and have all your registration information sent to this provider as well. If you want to understand the math, the app will show you everything based on provider prices, Amazon's maximum reimbursement rate, and the current status of your deductible and co-insurance out-of-pocket requirements. Next, she recommends rosuvastatin, or generic Crestor, for your cholesterol. It has nothing to do with your knee. She wants to do it while she's got you there. She taps her tablet, and your app immediately shows after insurance price options from a multitude of local and mail service pharmacies. The lowest price in this case happens to be from Amazon's own PillPack pharmacy. So you click Purchase. The pharmacy fills the doctor's prescription, submits a claim to Amazon, charges your share to your HSA, and delivers your Amazon Prime package within 24 hours, pandemic permitting. As you leave her office, your phone chimes and you see Dr. Thatcher's bill for the expected $78. So you click Approve and Pay from your HSA. The cloud-based Amazon administrative platform immediately executes the transaction through your bank, while simultaneously sending Amazon's share to Dr. Thatcher's account via same-day EFT, electronic funds transfer. Later, you get the unwelcome news that you need a total knee replacement. So you use your Amazon app and your doctor's advice to choose a 5-star top-rated orthopedic facility with an all-in price of $16,000, compared with the national average of nearly $50,000. Now, currently, either of these would exceed your annual out-of-pocket payment maximums to the point where you would no longer care about price. However, in this case, Amazon is offering you a savings bonus in the form of a $3,500 additional contribution to your HSA if you choose the high value, low cost option. And no, at this point, you don't get to have them do both your knees. Throughout this process, you have eliminated the costs and hassles of two intermediaries, the old preferred provider network and the pharmacy benefit manager, PBM, whose functions you and Amazon have now disintermediated out of existence. In addition, your app-enabled choices have driven claims transaction costs from 17% of the total to the 1% or so for your HSA debit card fee. This feature alone could save more than $500 billion a year in admin costs if applied across the entire healthcare system. And even this amount is unlikely to come close, I believe, to the savings that will be achieved from lower medical prices. The advantages of this system are many, and these slides will be available. But the elevator version is value shopping consumers will force providers to compete on quality and price, while creating a virtuous cycle that starts by showcasing providers with already low prices, and there are a lot of them out there, followed by providers identifying what they can be really good at, and then applying some savvy cost accounting, process reengineering, and continuous improvements to become high value, more focused providers for whom improved technology will finally become a driver of lower prices rather than a lame excuse for raising them. Now, what should government do under this scenario? Well, nothing. This is a purely private sector initiative that falls completely within current government rules. So if government wants to help, it should focus, in my opinion, on reforming Medicare, Medicaid, child health program, FEHB, Federal Employee Health Benefit Program, VA benefit plans with consumer-focused features like those I propose. My concern, though, is that government could succumb to rent-seeking incumbent interests that lobby to stop this from happening. So my hope is the government will, at the very least, do no harm. Joe, thanks for mentioning my book. Everything I've said here is covered in greater detail in it, How Jeff Bezos Can Fix Healthcare. Available, as Joe said, and appropriately enough, from Amazon.com. I hope you'll check it out and let me know what you think. Again, I thank the American Enterprise Institute and you all, and look forward to your comments and questions. Take it away, Joe.
Okay, thank you, Steve. It's a very optimistic view of government, certainly. The idea that they wouldn't be captured by existing interests. I don't think that probably resonates with a Washington audience because they've never seen that before, but you know, there's always a first time. We're not going to have a little discussion from Bob Grayboys, and then after Bob, I'll have a few comments, and then we'll you know, slap each other around a little bit as we often do at AEI, verbally, not physically. So Bob, why don't you unmute yourself and take it away?
All right. Good talk, Steve. Joe, too. Thanks for having me. So I'll try to be as negative as I can. Now, it's a good book and it's a good talk, and I enjoyed a lot of things. But our point here is to find points where, you know, initially where we disagree. So first of all, I'm going to reiterate what Joe said. In your book, I have the exact quote, "We won't be needing the government to do anything except not get in the way," which is kind of equivalent to my saying, if I want to fly by flapping my arms, the only thing I need is for gravity to get out of the way. And gravity hasn't done it yet, but like Joe said, there's always a first time. Now, but seriously, I'll give you an unfair critique. If I were writing your book, I would focus very heavily right at the start on that question, that government is in the way, and just saying we're going to just step aside and let things go won't do it, because there are so many rules, regulations, laws, and customs in place. State regulations, the Medicare reimbursement system, which will get in the way of a lot of what you're talking about, even if it's not Medicare. Our hospital regulations, even the FDA approval process, and the way we structure medical school and residencies. All of these things, government's already in the way. And it's not just a matter of saying, don't get in the way. It's you've got to get them out, or this thing is problematic. I know Jeff Bezos is something of a metaphor for your book. I don't know how literally you meant it to be Jeff Bezos as opposed to someone else, but I have enormous admiration for him, but he came out of nowhere. He was some Wall Street analyst with a briefcase who set up a bookstore and took over the world. And he's not that anymore. He does have quite a few employees, but you have something in your book that said, I forget how you put it, but I think it was a Clayton Christensen quote saying it can't be, the person to disrupt healthcare cannot be someone from the establishment. And I don't know that Jeff Bezos is not the establishment at this point. When they set up their when he set up this partnership with JP Morgan Chase and with Berkshire Hathaway, they kind of did very establishment things. I wrote about it at the time. Anyone out there can Google up my, just my sort of speculative piece at the time it came out. But the three companies decided they were going to do it as a not-for-profit. Well, those three people have, those three companies and the three CEOs have no experience other than doing things for profit. They've done wonderful things as a result of those profits. And I thought, why would they try to set out and do something in a way that they've never ever before? And you said in your book, no, they ought to go. Do it on a for-profit basis, which probably was my favorite line in your book. But it's not the way they started. And they also said, at least I think it was Christensen again, said you can't have someone from the medical establishment. Well, when they picked their CEO, they picked Atul Gawande, who you said correctly is a fine surgeon and a fine writer, but he's very much out of the medical culture, very much out of the medical mission. And finally, I would say, to a certain extent, what you set yourself up in doing in the book, and again, I like your book a lot, and I like your ideas, but you in essence kind of repeating what the arguments were for the managed care revolution or for the Affordable Care Act. You kind of became the central planner and laid out all the rules for a fantastic new world out there. If I were writing it, I would say what I want to do is to get the government out of the way and then to set it up so that not Jeff Bezos, but 100 different actors out there can come in with their own ideas, of which yours would be an excellent version for one of those people. But it might well be some guy working as Jeff Bezos did out of his garage initially, who is the one who actually comes up with the idea and the scheme and changes the world, as opposed to three very, very big companies that have sort of already gotten rather, rather comfortable in life. So those are my criticisms. When we get into the specifics, again, if we had a race going with 100 different firms trying to do this, what you've laid out are some excellent ideas on how one or more of them might choose some pieces to put into their plan. But I think the only way you get to this is by having a whole lot of different plans from a whole lot of different people, most of whom are going to fail. There was only one Amazon that arose from the internet revolution. He was it, and no one would have guessed Jeff Bezos to be the guy when it all started. So I'll stop at that point, and then you can come at me, and Joe can join in.
So actually, Steve, why don't you respond, and then I'll have some more comments after you're through.
Okay, the book you kind of wish I had written was actually one I wrote about 10 years ago about how the government can fix healthcare and create a consumer-based market economy across all, the government, private, and all that, they didn't pay a lot of attention. In fact, about 8 months after my book came out, they passed Obamacare, and off they went. You know, the guy or the woman struggling in their garage to get something off the ground is a classic American success story. And Bezos effectively was one of those. In this case, it could happen. It would need to be somebody with some unbelievable connections and salesmanship abilities, because at base, you gotta get an employer zero, a huge employer zero with a lot of market concentration in one market like Seattle or anywhere else, that has the combined contingent consumer purchasing power to convince, to create an environment in which the providers will sign up for this thing. We'll do that. And then the rest of it, you know, is directive. I've been working with self-insured employers for years and years and years. In every case, their self-funded health plans are run by human resources departments that do not have the knowledge, the skills, the resources, or the decision authority to pull anything like this off. It's not criticizing HR, it's just historical reasons they got stuck with it. That is probably the single biggest barrier to getting through any company that would start this thing, and Microsoft is as well, and I've proposed completely separate management structure and all of that. So I love the idea of a garage startup. I mean, it's, and I'm certainly not saying it's not doable, but in Bezos' case, he may be a member of the establishment, but he is not a member of the healthcare establishment. And he has none of the, he had no problem killing all the sacred cows in retail, and very successfully. So I'm suggesting he would equally not have any problem killing off the sacred cows in healthcare, or somebody like him.
Bob, were you going to say something?
I was just going to say, yeah, I had to unmute. I just said yes, or somebody like him. You know, a nice compromise might be a book, or how Jeff Bezos, or this guy, or that person, and that person, how one of them might do this. So we'll just compromise there.
All right. So the next book you and I'll co-author, and we'll work all this out.
We'll do that.
All right, Joe.
Okay, so thank you. You know, you make a number of important points that I think would resonate with the Washington audience, other than that business about somehow divorcing policy making and everything in Washington from its actual life. In particular, you know, perhaps the most important message is who controls the money really matters. You're saying that a real consumer-driven reform would put the money in the hands of the consumers. And I think, unfortunately, we have intermediaries to deal with. So I see at least two sort of categories of problems. One is, are consumers as ready to grab control of things as we would like them to be quickly enough for this kind of an idea to get off the ground? I would cite Amazon. I don't know how long it took Amazon to get to be the behemoth that it has become, and it certainly owes an awful lot to the health system. I mean, COVID-19, for its gigantic success lately. But it didn't happen overnight. And one of the challenges here is kind of a scale issue. You have to convince, or you have to have a large enough group of consumers ready to act. You have to have a large enough group of employers ready to sign on, because that's where people are getting their health insurance. And that last point that one of you made about the HR department, this of course does not apply to AEI, but the HR department, convincing the HR department to part ways with whatever they're used to is very, very difficult. In fact, I think what we've seen is that the only time a big employers really did anything was when the CEO said, "Hey, we've got a problem." It resides at that level. And the problem with getting the CEO interested is that healthcare is not their business. So it's a real challenge to do this. When there's a huge spike in cost that the CEO can see, coupled with complaints from their most important employees, which, by the way, are not the executive vice presidents, it's the people who are really doing the work, then they pay attention. But basically, they want it to go away. They want somebody to handle it. And I think that startup, I think, is a real concern. How do you get it to start up? In essence, I guess I'm arguing that if you can't have a fast startup, then I'm not sure where you are.
Okay.
I have other comments, but Steve, do you have a thought about that?
Okay. Are consumers ready to do this? What I'm trying to do with this design is allow consumers to do it based on we already have the best trained, most experienced consumers on the face of the planet for everything they buy, virtually except healthcare. And it's all based, either consciously or otherwise, on getting the information on those two issues, quality and price. Quality divided by price equals value. The higher the quality, the lower the price, the higher the value. And that's the way we buy everything. We can't do that in healthcare. And even if we could, under the current structure of most health benefits, nobody would bother. You know, why should I? It doesn't matter. If I'm paying a $20 copayment, that's my price. I don't care. And if I have a maximum out of pocket this year of $1,000, what do I care whether the MRI costs $2,000 or $20,000? The insurance is picking it up. So you got to create a reason for them to care. And great way for them to care is give them not only skin in the game, a chunk of money and an HSA contribution. Say, look, you're responsible for the first X $1,000s of what you got to buy. And that HSA, by the way, is yours forever. You can use it as a retirement plan. It's tax-free. It's the best tax dodge going. But we're going to show you now how to get that information. And if you want to spend it all, you can do that. If you want to get the $55,000 knee replacement, you can do it. But you're going to be giving up all of your money rather than being able to build up, as my children have over the last 10 years with their HSA, tens of thousands of dollars in savings against future medical problems and retirement needs. So it's going to take some training, but until we have that, we have to have the incentives, skin in the game on the consumer side, and the readily available information. 90% of the population has a smartphone. And we don't need the old ones to do it because they're on Medicare, and that doesn't count here yet.
I beg your pardon?
No, guys, who cares? You know, we can't get there because of Medicare. I cover that in the book, what it could do. As far as you're right about the whole HR thing. It's a CEO sell. That's why I named the book How Jeff Bezos Can Fix Healthcare rather than How Amazon's HR department can fix healthcare. Not quite as catchy either, but it's a key piece. But Amazon desperately wants to be in healthcare. Google it, jillions of stuff comes up. Microsoft, same thing. Google, God forbid they do this for other reasons. The patient isn't the product with this thing. Their information is not the product. So yeah, it's hard. It's damnably difficult to do this. That's why it requires somebody with deep pockets, strategic patience, and a determination. Somebody like Bezos, he planned on zero margins for decades, and it seems to be working.
Yeah. So let me make one other observation and go back to Bob, and that is, you're absolutely right that given the right information structure and given obvious financial incentives, and then absolutely consumers are fully prepared to do what's right for them, which isn't necessarily the lowest cost, but what's right for them. I mean, there could be a convenience factor, that sort of thing. A good example that I think many people know is the CalPERS example. This is California Personnel Retirement System, which accounts for many thousands of California, state government employees. And I think it also includes local school district employees who are over the age of 65 and so on. And a number of years ago, they realized that they were being taken to the cleaners by fairly straightforward joint replacement surgeries. They were paying an enormous amount of money. They took a look at it and they saw there was a vast range of prices. And this is, by the way, not with negotiation. They just saw a vast range of prices. And they realized that, well, maybe there wasn't that much difference in what the service was. There is generally not that much difference in terms of the other comorbidities of the patient. It's to coin a phrase, it's fairly cut and dried. So they, I think they probably hired a consultant, but anyway, someone went out to the main hospitals that were providing these services to their members, and they said, give us your best price. And what we're going to do is we're going to determine a fixed amount that we are going to pay for, let's say, a knee replacement. We're going to determine a fixed amount. We're going to pay it no matter that amount, no matter where our enrollee goes. So if he goes to your hospital, we're going to cover, X dollars. If he goes to some other hospital, we're going to cover the same X dollars, and it's up to the enrollee to cover the rest. Well, two things happened. One is that fairly immediately, once the CalPERS enrollees understood what the deal was, they got the idea that they were going to pay more if they went to a more expensive place, and they did have a kind of the list of information. You didn't need fancy communication in that case because it was really very straightforward. You could identify who the enrollees were who would be interested in this information, and there were a limited number of providers that provided the service. People caught on right away. I'm going to have to pay, $1,000 more if I go to this hospital, $5,000 more if I go to another hospital. I might actually save money if I go to a third hospital. But the most important factor was the hospitals caught on, and very quickly, the high-priced hospitals lowered their prices because they were losing business. And that's the critical message here. Unless somebody feels it in their wallet, it can't happen. So you have to make sure they feel it in their wallet. Mm-hmm. And that really calls for, again, it's kind of a scale issue here. How do you scale up fast enough so that the pain is felt strongly enough to wake people up in the health industry?
And,
Go ahead.
Yeah, and I was going to say, piggybacking on that. So by the way, I'm very sympathetic to the line of argumentation. My doctoral dissertation 20 years ago was on exactly this question. How can you structure health insurance in such a way that the patient really has a powerful motivation to consider things? So I am sympathetic. You're going to have a big climb, socially, politically, what have you, because there is a substantial swath of the American political community and public that thinks that high deductible health plans are just a terrible idea, and that first dollar coverage is humane and a necessity. So that's something of a problem. And I also wanted to say one other thing, that a thread through your book, that you're effectively calling for the elimination of negotiating with insurers and for uh, much greater transparency can itself yield problems. I'm writing a couple papers on it now. It's called the tacit collusion problem, well known in industrial organization economics, where if everyone's prices are public, you can get, under certain circumstances, which are quite common in American healthcare, transparency can actually cause the prices to rise because all of us, the three of us, are the hospitals in a town, and I know no point in my lowering it because Joe and Steve aren't lowering theirs. Joe and Steve are thinking the same, so we all rise. And in a number of cases in healthcare, in pharmaceuticals, in hospitals, even in primary care at this point, there have been warnings from antitrust authorities that excessive transparency, as paradoxical as that can sound, can again yield this paradoxical result of pushing prices upward. So it's something that has to be done with great care.
Yeah, I agree. Of course, if somebody gets caught price fixing, the treble damages can be pretty damaging.
They don't have to coordinate if there are a modest number of providers. They just wink to the eye and
The main thing is you need an awful lot of price discipline in a deal like that. Airlines are a great example. Robert Crandall, who used to run American Airlines, says, "Man, it's tough being in a business where you're only allowed to be as smart as your dumbest competitor." In other words, as long as we all keep our prices high, we're all in gravy. But all it takes is a Southwest Airlines or back then Trans-Texas or whatever to drop their price, and you got to match it. And there is a quasi example, and I mentioned it in the book in some detail. In Washington State, you can actually find the all-in prices for a whole bunch of surgical procedures in a whole bunch of hospitals. It's the all-payer claims database that nobody looks at as a consumer. But if you go in there, you find out there's wide, almost extreme variation in prices of things like tonsillectomies, appendectomies, knee replacements that is public, has been public for a long time. And arguably that is signaling to the low price guys, hey, I need to argue for higher prices in negotiating my insurance contracts because somebody else is getting it. But you're also kind of assuming the price is the only issue that drives competition because everybody's got the same prices. And one hospital is dominant in other areas, they have geographic advantage, whatever, then they're going to get the business. As soon as it's high fixed cost business, so pricing is can be very fluid there. Once the price is not a matter, I'll go where it's most convenient, it has the prettiest building or whatever it is. And as soon as volume starts disappearing from the other guys, see what happens to price discipline. It's a very interesting issue. I'm very much looking forward to reading your papers on that and seeing how it impacts.
Hope they'll be around soon.
Good, thank you.
So there's one other aspect to this conversation, which is not a health sector aspect. It's a labor market issue, and that is that in a tight labor market, which we hope to return to someday, but we certainly had last year, in a tight labor market, employers are very reluctant to make changes in their health plans.
Yeah.
And the reason is that, first of all, any change, under the current circumstances, the culture is such that I think any change is immediately viewed with suspicion and therefore viewed negatively, even if it's a positive change. Ignorance has to do with that, but it's also unfamiliarity. You don't know how it works. So from the employee's standpoint, that's a problem. And you don't want to, in a tight labor market, you don't want to mess that up because, again, what is your business? It's not health insurance, it's widgets. And you got to be able to produce those widgets, and you need the master widget maker to stay with you. So that's one of the barriers.
Yeah.
You
Can
know,
I comment on that before?
well, one other aspect of that is that where, for example, Boeing or some other big companies have sort of branched out and again pick things like joint replacements and you know uh, found a provider that was the best in the country in some cases and said we're going to send all of our people there and that'll get us a better deal, and not only that but the results will come out better. In the case of, I think it was Boeing, it was spine surgery, and the goal was not to get better spine surgery, it was to get better advice to the patient. You don't need spine surgery, you need physical therapy. But all of those things that what people called innovations are within the existing structure. They didn't actually change anything. And I think it's that labor market factor that really drives that, or has driven it so far.
Your point on the perception of a deterioration in health benefits, and it goes back to Bob's comment about zero cost care. People want free care. Whoever does this has to make the health plan better. When I talk about modifying it to a modified high deductible, yada, 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 it net has to be better than essentially any other health plan that company is offering. And in fact, it can conceivably, and I discuss this in the book, become 100% payment, that it covers everything. But a lot of that money is being managed out of the HSA. If there's plenty of money in here, arguably this is doable because we're shrinking the pie, the total cost of healthcare, potentially by so much. I think a third to a half within 5 or 7 years if the thing gets wide, or wherever this thing is adopted. Then the benefits can become far, far richer, but you're restructuring it in the form of incentives so that people the workers, I don't want to spend the money on healthcare. I hate healthcare anyway. I never want to spend money on healthcare. It's the main thing people buy that they don't want to buy. I want to keep the money and use it for my own use. And that's what this can allow. The Boeing thing of picking a winner and all that, this is just more kind of top-down paternalism. Okay, let's pick something and see what happens. I'm talking about system-wide change, where you don't count on people who's in HR or anywhere else whose business is not healthcare to make decisions anymore for what's good for people. You let people decide for themselves. And yes, there will be a transition phase for people. Their initial response will always be, holy crap, they're cutting my health benefits and I got to start doing stuff I don't know how to do. And I've actually dealt with this in a number of employers, mostly on prescription drug benefits. And you would be astonished at how much you can alleviate that concern, that stress, by getting in front of a bunch of workers and saying, all right, look, we're changing the health plan. Here it is. I know this is going to be really stressful to a lot of you, unless you listen to what you're going to hear for the next hour, in which case I think you're all going to like it. And you structure it in such a way that that should be the outcome. Not all, but almost everybody. All economics happens on the margin. But I've had enough experience in that, meeting with people on the factory floor, that if you explain the rules and you keep it simple, which we are, you should be able to get through it. But HR lives in perpetual fear of that phone ringing with a complaint. And that drives so many of the decisions.
Right.
You got to get it out of HR.
Certainly the phasing is critically important.
Yeah.
The companies that adopted high deductible health plans with HSAs, if they did it right, it was popular. And if they did it wrong, everybody hated it.
Right. But the problem with even the HSAs there, even if they liked it, they have shown they save money, but almost all the money they save isn't from people going to lower price care because they can't find prices. It's just from not getting care. Fortunately, most of the care they're not getting, they didn't need anyway. And in fact, that's true across the board, except for poor people. It's the old RAND study that was done back in the 80s that demonstrated that. But yeah.
Okay, so I have a couple of questions from the audience. The first one that I see is, how successful can this approach be? And this is really pointing at the pharmaceutical market, but I think it's a more general question than that. I'll ask it the way it was provided. How successful can this approach be in the drug market, given Medicare's dominance in that market?
Of course, Medicare doesn't control prices in that in that market. It's purely a bunch of private sector providers on that. So Medicare actually doesn't have a lot of control over drug prices. Medicaid has more than Medicare because of the rebate structure of how they do that. But a short answer to the question is that in stage 2 of the transition, there's no PBM. You're dealing purely between the patient and pharmacies. And whichever pharmacy has the lowest price and the most acceptable service will get, like the rosuvastatin example I gave. Initially,
Hey, Steve, I meant for you to kind of answer it in general. I think the real question isn't so much drugs as the dominance of Medicare in its regulatory authority.
Oh, yeah.
Everything that happens, at least as far as providers are concerned.
Yeah, I've done a lot of work on Medicare with clients and stuff, and this is outside of Medicare. I mean, you're talking about 170 million people with private health insurance that Medicare certainly affects, and especially the resource-based relative value scale and the effectively government price setting that what I'm proposing does away with.
I'm not talking about price setting. I'm talking about regulation. I'm talking about them telling hospitals and doctors how they're supposed to do things. I think that's a huge challenge.
I've often written
pricing. Go ahead, Bob.
Yeah, I've often written that we are effectively all on Medicare. That my private plan through my insurer is effectively a Medicare plan with tweaks.
That is essentially true. Mm-hmm. What I'm talking about, though, is it doesn't have to be that way. It's most convenient for the current insurers. It's most convenient for the hospitals to structure the private sector transactions in concert with Medicare. What I'm suggesting is they can break away from that. They don't have to do that anymore because it can be a more profitable model for both the payer and the provider by saying, okay, we got to do a Medicare. We got to do what they require. There's no way around that, but we don't have to do that anymore with the private sector.
Okay, so let me ask. We only have 2 minutes left. Let me ask one last audience question, and please respond quickly.
Yeah.
Given the asymmetry of information between physicians and patients, how can we expect consumers to make the right choices for their own care? I think this is a softball.
Yeah, I'm happy. Go ahead.
It's if the patient can be communicated value information, quality for their need, for their purposes, fitness for need for their purposes, and price, then that asymmetry goes away. And in fact, the physician and the patient become allies in this thing against the payers who are now, they're the enemy. And now the physician can set their own prices. It's purely a doctor-patient relationship. So whatever asymmetry was there before is taken away by bringing in all the transaction information and making it transparent. And patients get to choose based on value with advice where they need it on complex stuff.
Right, that's the critical thing. They're not going to lose their doctor. And they will need that advice for the complicated things, and they'll be able to.
If you like your doctor, you can keep your doctor.
Uh-oh.
And I'll just say, there is an asymmetry between the knowledge that I have and my doctor has. There's also a similar asymmetry between me and the guy who fixes my car brakes, who I can get killed if that guy doesn't do it right, and the guy who fixes my gas heater. And there are an awful lot of places in life where I am relying on someone to do something I have no knowledge of, and if he does it wrong, I'm going to die. So I think medicine is not nearly as unique as we think it is in that respect.
So one last quip, and then we'll have to sign off, and that is healthcare doctors are the only profession that can knock you out before they pick your pocket. And with that thought, which probably will really annoy our donors, I want to thank Steve and Bob and the audience for a really great conversation. Until next time, thanks again.
Thank you, guys.
Thank you all.